Well, hello everyone. I am Dr. Santosh Saraf. On behalf of CME Outfitters, I'd like to welcome and thank you for joining us for today's educational activity titled Bridging Gaps in Advancing Care in Sickle Cell Disease in the Context of Drug Therapy. Today's program is supported by an educational grant from Novo Nordisk. This activity may include discussions of products or devices that are not currently labeled for use by the FDA. The faculty have been informed of the responsibility to disclose to the audience if they will be discussing off-label or investigational uses, any uses not approved by the FDA of products or devices. So as I mentioned, I am Santosh Saraf. I'm an associate professor of medicine at the University of Illinois Chicago, and I care for adults with sickle cell disease. And I'm delighted to be joined today by two distinguished colleagues whom I'll ask to introduce themselves, starting with you, Maya, please.
Hi, everyone. My name is Maya Bloomberg. I'm a hematology nurse practitioner specializing in sickle cell and also congenital bleeding disorders, which shed light on the disparities that we are going to be highlighting a little bit about today. I care for adult patients at University of Miami and Jackson Memorial Hospital, and I'm very happy to be here tonight.
Thank you.
Hi, everybody. Good evening. My name is Laura De Castro. I'm a professor of medicine at the University of Pittsburgh. I am the clinical chief of the Division of Benign Hematology. My passion and my area of clinical care, research, and teaching is sickle cell disease and other hemoglobinopathies. Thank you.
Thank you. All right, well, let's start by going over our learning objectives for today. Our first learning objective is to identify the importance of comprehensive, team-based therapeutic and supportive care in preventing end organ damage and improving quality of life in patients with sickle cell disease. Our second learning objective is to assess the effectiveness and challenges of current therapies to address the burden of disease in patients with sickle cell disease. And our third learning objective is to evaluate future directions in sickle cell disease treatment, including combination therapies, long-term efficacy, and safety studies of new interventions and investigational agents. Now I'll turn things over to Maya, who will talk to you about the burden of disease in sickle cell disease.
Thank you, Dr. Saraf. So to get the audience involved and start our discussion tonight, I'm going to start with a question. And these are just opinion questions, so don't need to worry about getting anything wrong. We just want to know what you're thinking. So the question to start is, what measure beyond acute pain do you consider most important when determining severity of sickle cell disease? So it seems like a lot of people base it off of the quality of life and end organ damage. And through my portion of the presentation, we'll kind of discuss a different framework that can be used to kind of stratify the severity of our patients. All right. So when we think about sickle cell, pain and anemia often dominate the conversation. However, we have morbidity and mortality data that reveal significant gaps in care, highlighting the life-shortening cumulative burden of chronic complications caused by sickle cell. This slide highlights the life expectancy trends and age-specific mortality rates, underscoring the broader unmet needs across the lifespan for individuals with sickle cell. We can see that there's been significant progress made in pediatrics with newborn screening leading to early identification, which allows for vaccination and penicillin prophylaxis and hydroxyurea usage, where more than 95% of children will survive into adulthood in high-resource countries. However, the life expectancy still remains reduced, averaging 20 to 30 years lower for patients with sickle cell compared to the general population, and it's due to the head-to-toe acute and chronic complications. So again, on that right-hand side, we can see the obvious progress in pediatrics, but we see that spike in mortality during that transition period, which remains elevated throughout adulthood, emphasizing the importance of the need for advancing our therapies that target that underlying pathology and protect organs over time. Moving on to mortality data. This is the data from the SCDIS registry, which highlights the sickle cell complications beyond pain crises that drive mortality, particularly among young adults. Cardiac complications are the leading cause of death, followed by unknown causes and multi-organ failure. These findings emphasize, again, that cumulative burden of chronic organ damage, which can go unrecognized until it's too late, especially if the person isn't being followed at a comprehensive sickle cell center. 25 to 34 really is a critical age group where individuals between this age with 2 or more sickle cell complications are more likely to die compared to those with less than 1 complication. And transition likely impacts this data, but again, it's highlighting how we need to really just need an approach targeting chronic complications, especially for high-risk adults, and to improve the outcomes among this population. Now, this slide shows the hazard ratios for comorbid conditions contributing to mortality in sickle cell patients. The further the dot and the bar shift to the right, the higher the risk of death. And the conditions that had the strongest association with death, interestingly, was depression, iron overload, pulmonary hypertension, multi-organ failure, sepsis, and acute chest. And these findings emphasize how both chronic physical complications and the mental health conditions drive mortality risk. And my goal from my section is for everyone to truly understand that sickle cell is a systemic disease, and we need to manage these comorbidities proactively to reduce mortality and improve quality of life. Now, when we think about severity of sickle cell, we often base it off of the frequency of pain crises and acute care visits for vaso-occlusive crises. However, this group obviously determines based on quality of life and the parameters that I, as a provider, emphasize the most. But to really fully understand how severe and what that impact is on an individual, we need to consider the organ damage, for example, kidney failure. We also need to follow the patient quality of life metrics such as fatigue and mental health and functional limitations. And then also the type of pain, since chronic pain can be just as debilitating as an acute VOC crisis. And if we only rely on acute pain episodes, we're more than likely going to underestimate the true burden of this disease. And by addressing these broader measures, we're able to just meet the full spectrum of our patient needs. Now, here we have a model to assist in stratifying sickle cell patients into 3 severity classes, class 1, 2, and 3, based on key clinical indicators in order to help providers just tailor treatment strategies and allocate resources. Class 3 is severe disease. These are patients with severe organ damage, and we don't want to let our patients get to this point. And this is why we have sickle cell guidelines that stress the importance of early screening and monitoring to prevent progression. But also in this category are patients with 5 or more VOCs or acute care visits in a year. Class 2 is moderate disease, so this is going to be your patients with mild or moderate organ damage and or chronic pain. And then lastly, we have class 1, which is a more mild disease. Anybody who's between 8 and 40 years old with less than 2 crises or acute care visits in the year fall within that category. And the framework just emphasizes how sickle cell isn't a one-size-fits-all disease and integrates the acute events, the chronic complications, and the organ involvement to provide a little bit more of a holistic view of severity. Now, this slide is a little bit busy, but it highlights the SHAPE survey of patients living with sickle cell disease, which stood for Sickle Cell Health Awareness, Perspectives, and Experiences. And it aimed to assess the multidimensional impact of sickle cell on patients' lives, focusing both on the physical symptoms and the psychosocial challenges. Pain, fatigue, and bone aches dominate pretty much every aspect of the life for these patients. You can see that 26% reported that pain was the biggest factor contributing to one's ability to attend or succeed at work or school, and pain impacted nearly a quarter of patients, which then impacts their daily function and overall hope for the future. Looking to the right of the screen highlights the psychological impacts of sickle cell. You can see 79% worry about being a burden to those around them. 76 to 83% believe sickle cell isn't seen as important as other conditions in society. 63% fear that judgments for those or about being seen as less competent at work. A lot of people kept it a secret from most people, especially among adolescents, which kind of points to that significant stigma and isolation, which can then impact relationships and mental health and sense of belonging. And we all understand that interconnectedness of our mental health and physical health, and it really creates almost this vicious cycle for patients if they don't have that mental resiliency and the appropriate support to navigate the system. And I think the survey ultimately underscores that sickle cell isn't just a medical condition. It's a life-altering condition that impacts physical, emotional, and social well-being. And because of that, we have to take a comprehensive, patient-centric approach to improve outcomes for these patients. And we can do this by adopting a team-based or a multidisciplinary approach that extends far beyond just the hematologist following the patient. We need to work with primary care providers to ensure that preventative care and vaccinations and general health maintenance is taken care of. And having a good PCP is extremely important. And unfortunately, there was a survey that found that a fraction of primary care providers felt comfortable treating individuals with sickle cell, which shows how much more we need to do to increase confidence and spread awareness and educate. There's so many specialists involved as well in this multidisciplinary team approach, including your pain specialists and cardiologists, pulmonologists, nephrology, physical therapy, since we know avascular necrosis is a chronic complication and is the #1 cause of chronic pain. And then we need our nurses and our social workers for education and coordination and support for just the day-to-day care. And then we have to always remember at that center is the patient and the family. Sickle cell truly impacts the entire family, and it's therefore essential to include the patient and the caregiver and their support systems into any conversation that we're having. And by adopting this team-based approach, it really ensures that there's no aspect of care that's being overlooked and can help bridge gaps in care and improve outcomes for this population. Now I'd like to hear about the impacts of sickle cell on patients directly from a sickle cell warrior themselves.
My name is Judy Gray Johnson, and I was born in January 5th, 1943. I can tell you that for every day that I can remember, I have always known that or felt like I was different than other children. And that is something that I lived with over the years. So in other words, I've always been the person that was different in the group. I can look back now over 81 years and feel like I've been a prisoner all these years because my life has been consumed with sickle cell pain in some form or another. Well, from up until the age of 16, understand I went through all of the pain crises that you may be familiar with or that you're aware of, okay? But I had no medication whatsoever from birth up to 21 years of age. This is what I had to go through. So there was no take this medication and take that medication. I was a full-grown adult before someone gave me hydroxyurea. I have had that. The first time that I received hydroxyurea, I was in the hospital, but I remember that there was a consultant for the doctor on the call, that was the hospitalist on the call, and whatever they knew about me, they consulted with the hospitalist, not me, but they just came in, looked at me, and said, here's some medication I want you to take. I believe it was 1,000 milligrams, the total of 1,000 milligrams of that hydroxyurea. And I just took whatever they asked me to. But however, shortly after that, when I went home, I remember getting paralyzed. You see, I could not get out of bed and stand straight up. I had to scoot myself out of the bed, and it was very difficult. That was my first experience with hydroxyurea. In other words, I was paralyzed. And so I stopped taking it after consulting with the doctor, and I said, I don't know what this is, but it's not working. Well, anyway, after I stayed off it for a while, and I would say many years later, when I had the nerve to try it again, they put me on 500 milligrams which appears to be working or effective. But it seemed like the method of treatment during that time, it was not the pills, it was blood transfusions. Whenever there was a pain crisis, they immediately would reach for a transfusion. It wears on the kidneys, and my kidneys, I now am on dialysis.
Well, I don't know if you guys caught it or not, but she's actually over 80 years old living with sickle cell, which is amazing. My oldest patient is going to be 82 this year with sickle cell, which is just a big feat because a lot of these patients and families are told they're not going to live beyond a certain age, which that alone carries its own psychological impact for both the patients and the caregivers for that. I'd like to open the faculty discussion and just bring back Dr. Saraf and Dr. DeCastro and kind of just get your feedback from what I presented and from her video. How are we managing or even really improving the quality of life for our patients with sickle cell? I know we're having advancements, and Dr. Straff has a lovely presentation later on the different treatments and therapies in the pipeline, which will hopefully help improve that. But it's been a long time coming, and a lot of patients haven't fully been able to benefit from a lot of some of the advancements that we're seeing.
But I think it's a really important question, and based on that survey, quality of life was the number one issue that came up on the survey. So it's a very important issue. It's still an issue that we need to handle. But I think hydroxyurea is probably a really important medication to start early, offer to the patients, titrate as they can tolerate, and I think that really helps improve or mitigate some of the long-term issues, including organ damage and hopefully improving the quality of life.
I agree.
So one of the things that I feel that us as a clinician and researcher paying more attention while we develop new therapies and hopefully have more available curative therapies like bone marrow transplant is that we have to hear the voice of the patient and what is important for them. And for years, like Judy said, she was given a pill. She wasn't explained what was it for. She was started at a dose, and it doesn't look like there was a close follow-up of what to do. And we have been, with the few tools that we have, therapeutic ones to give to the patients, we, I think, have forgotten to really put the patients on front and try to find out what are the patients' need and what do they feel are more impactful for a disease that they have lived with. And they're expecting most of them to live for the rest of their life. That's one area that I wanted to highlight. The other area is the impact of comprehensive care, i.e., I think they go a lot together because us as a clinician tend to be to address more symptoms, testing, laboratories, but not the other components of the illness that needs to be addressed. For example, again, Judy is now on dialysis, and sometimes even with us looking at creatinine and laboratory testing and all that, we forget, in fact, choices that patients would like in regard with further treatment and when to start and how to explain to them exactly, why we are recommending other physicians to evaluate them and what is their expectation. So I think we're moving in the right direction, but we still have a lot to do with that.
I liked the comments about really capturing the patient voice because I feel like we've shifted so much from that paternalistic type of decision making where the providers assume they know everything and kind of dictate what the plan is and are really starting to utilize shared decision making because granted, we don't have a ton of options, but we're starting to have options that's allowing us to take a little bit more of a patient-centric, individualized approach towards managing our patients with sickle cell. And we need to involve the patients in the decision-making when we're choosing what therapies are best for them, because there's so much more than just prescribing a medicine that goes into health outcomes. And Dr. DeCastro, I know you're going to be touching a lot on the social determinants of health and those type of factors, but if you're prescribing in a monthly IV infusion and there's transportation issues or high out of pocket, like we need to work with the patient and first learn what are their treatment goals, because as we mentioned, like hydroxyurea, favorite drug, there's so many benefits. I mean, the only medicine we can say is going to make you live longer with sickle cell However, it wasn't created for sickle cell. It is classified as a chemo agent, even though we know that it does not act like traditional chemos, but there's certain stigmatization towards the therapies that we have that prevent patients from necessarily wanting to be on it. So we kind of have to work with the patients and really see what are their goals out of the treatment, and then kindly educate them and really take the time to educate, because you pointed out so many points from Judy's case where she was just told what to do and she kind of complied, but not all patients are like that. And I think we can all agree when patients understand the why behind certain decisions and certain orders and certain medications, they're so much more likely to actually comply and adhere to that regimen. And then from a comprehensive care standpoint, I mean, I'm the adult nurse coordinator at our hemophilia treatment center, and we have so much data on just how comprehensive care reduces morbidity and mortality. And it's frustrating that we're so behind in just realizing and getting more resources and support from the sickle cell side to do that. But it is happening. It's been a kind of an uphill battle, but there is progress that's being made, just a little bit slower. The last question I kind of want to touch before handing it over to Dr. DeCastro is just talking a little bit more about the role of a multidisciplinary team when it comes to sickle cell management. I kind of highlighted a lot of the players and people who should be involved, but I'm curious, like at your institutions, how do you, because some providers want less hands is better because then you have too many opinions, while others might refer a little faster. So I'm curious what your guys' approach is towards that.
I think for a chronic organ disease or chronic disease like sickle cell disease, multidisciplinary really is helpful. And a lot of the things that you all brought up, good psychosocial help, I think this ties back to quality of life. But having the social work support, we have a Illinois Department of Public Health grant where everybody's going to get screened, neuropsychological screening. And I think those kind of things are really helpful for people as they're working on their educational goals and life goals. So I think a multidisciplinary approach is really, really important. Social work, mental health, and then people that are monitoring organ function are important players.
So my experience is that, especially for places that have a sickle cell center, multidisciplinary approach really help with following the patient from multiple points of view. And then members of the multidisciplinary center don't necessarily have to see the patient or be in one location, as long as there is a good understanding of who are the orthopedics and the pulmonologists and the psychiatrists, and in addition to that center core, which are the nurses and the social worker and the hematologists that can take care of this patient and that are comfortable following this patient and that will manage parts like hypertension of GYN issues that, that patients often rely on their hematologists because they say, oh, you're the one that knows sickle cell disease. But it's important that we identify within our institution or within our communities providers that are able to work together with us, that we can hold their hands when they feel that they need to hold their hands, but that also have their specialty to support some of the multiple needs of this patient population. And knowing that those needs may change over time. We know that during childhood, and especially in places like in the United States, where more than 90% of children survive at age 18, then the complications that we see on that very fragile age of 18 to mid-20s and beyond. So it's important to identify at each level different providers that are part of our large comprehensive care that will manage our patients with us. The other issue that I wanted to highlight is that not every provider, not every physician, not every primary care or hematologist have the availability to have a comprehensive center or to work directly on a comprehensive center. And what studies have shown in multiple populations is that even when we identify based on demographic patients that with sickle cell disease that are managed at a comprehensive center, there is a group of patients, maybe over 40%, that are not managed in the comprehensive center that is managed in the community. So activities that like this one that allow for to reach outside from the usual core of clinicians and providers that are familiar with sickle cell disease and that help them to understand the need of having a referral base and have to work with a center, even if they are long distance, are very important to reaffirm the need to care for those patients that are in the community and that for one reason or another are not followed normally or regularly with all the with the comprehensive sickle cell center that have that multidisciplinary team.
And I think this is where telemedicine is very helpful because we'll have patients who will be the virtual comprehensive sickle cell per se, and then they'll have their local hematologist who we work with. We're very fortunate at our center that we have a very wide multidisciplinary approach in almost any specialty. We have providers who are comfortable with sickle cell, but it didn't start that way. And it's just a matter of identifying somebody who is open to learning a little bit more. And that's just the seed that you need to just start getting more and more providers who are comfortable and creating that network, because it doesn't happen overnight. And there's a lot of teaching that's necessary, especially in the emergency departments. So doing grand rounds and just taking the initiative as providers and letting our patients know you can provide our contact information. We want to be involved, especially when they're going to specialists outside of your institution. It's just going to help with the collaboration and just make sure that there's not something that's going overlooked or mismanagement that could potentially happen.
Yeah, that's a great point. The televisits, one of the few good things out of COVID was the ability for everybody to have access to televisits.
Yeah.
And the American Society of Hematology also has some core infrastructure that a comprehensive center should have, and that's also a pretty good blueprint for multidisciplinary care.
Well, I think now is a good time for me to hand things over to Dr. DeCastro to discuss where we are in the treatment of sickle cell disease and some of the challenges we're facing there.
Thank you. So I would like to start with another question. Basically, of the 5 American Society of Hematology treatment guidelines for sickle cell disease, I would like to know what is the audience preference most often in your clinical practice? Okay, so we have here the most relevant answers, and as expected, the guideline that is most used is the one that address acute and chronic pain, since pain is the hallmark of the disease and what brings patient more to the healthcare system for management. But second was the cardiopulmonary and kidney disease, which is one of the chronic complications, and then the transfusion support. I wanted to, before I move on, I wanted to remind everybody that these guidelines are available both at the American Society of Hematology website, but also you can download on your cell phone and carry with you. This is a source that I give to all the residents and fellows, because you can access them as you go and get some very good indications of what to address. So back to our presentation, we'd like to remind everybody that, again, even though the pain is the hallmark of the disease and what brings patient more to the hospital, we cannot forget that this disease involves multiple organ complications, both acute and chronic, and that these complications do not happen in by themselves, but you can have an individual that have had a stroke, is developing a vascular necrosis, and is also have gallstones and need to have a cholecystectomy. So I tend to remind everybody that there are some acute complications in addition to pain, such as sepsis, such as changes on vision, etc., but that those chronic complications, the pulmonary hypertension, the kidney disease, the heart issues, including heart hypertrophy, the hepatopathy, the kidney disease, and the osteonecrosis are the ones that we see, and we need to take care on a long-term basis to improve not only the well-being of these patients, but overall the survival, because there's multiple data that have shown that the more complications a patient presents with, the higher morbidity and mortality these patients can have. So I want to move a little bit again about the guidelines, and the most updated one at this point are the ASH guidelines that I mentioned before. Again, you can get them on hematology.org or and download it in your mobile cellular phone and have with you all the time. But I also want to highlight that there's the availability of a point of care toolkit, and toolkit have become very relevant because kind of give us a step-by-step um, guidance of what to look for and how to manage. And this CME has a point of care toolkit on sickle cell that will be available to each of you after completing this at the end of this presentation. We'd like to move forward then at the primary pharmacotherapy for sickle cell disease. And one of the issues that I want to put emphasis on is that what you're seeing here are the 4 FDA-approved medications that have been used for the last 26 years to address complication of sickle cell disease, specifically of sickle cell disease. All of these medications have been approved by FDA under a program that is address rare diseases and rapid approval of medication through that. The first one, hydroxyurea, that was mentioned earlier by both of my co-presenters, was initially investigated for sickle cell disease, even though it's a medication that's been used for more than 80 years. But for sickle cell disease was initially studied in the 1990s. And the multicenter study on hydroxyurea, or MSH, that was concluded around 1998 prompted the FDA approval of this medication as the first medication disease-specific to treat sickle cell patients. And this was on the basis of this study, the MSH, finding that hydroxyurea decreased the frequency of vaso-occlusive episode, VOC here, in those 150 patients out of 300 that were taking the drug, and not only decrease the frequency, but also decrease the intensity of the VOC. This study had a 20 years follow-up study that have concluded that hydroxyurea not only giving the mechanism of action of stimulating the fetal hemoglobin production, reduce vaso-occlusive crisis, the frequency and the intensity, but that hydroxyurea impact multiple aspects of sickle cell disease, from improving hemoglobin, decreasing hemolysis, especially by measuring LDH, decreasing reticulocyte count, decreasing white blood cells and platelets that are associated with the activation with vaso-occlusive episode. So now hydroxyurea is considered not only the best medication, but the initial medication to treat patients 2 years and older with that have sickle cell disease. The use in pediatric was approved in 2017, not too long ago, for, again, patients 2 years and older, but I have pediatric colleagues that have used it for patients as young as 9 months of age, based on their presentation as a newborn and their complications. So L-glutamine, the second one that was approved by the FDA specifically for management of sickle cell disease, was approved in 2017. Although the mechanism of action is not clear yet, it increased the uptake in sickle cell and reduced adherence of sickle cells to the endothelium. It was approved on the basis of a relatively small study, but it's used and prescribed because it's an oral powder drug that is easy to take and very available, and he has shown to reduce the frequency of vaso-occlusive episodes. The last 2 drugs were approved both in 2019 a little bit before COVID. So the implementation of the use of this drug was slowly in the first, in the 2021-22. Crisalucimab, which is a humanized monoclonal antibody to P-selectin, works by inhibiting adhesion of not only red cells, sickle red cells, but also white cells and platelets, and by that, decreasing the development of VOC. This is an intravenous medication that has to be given every 4 weeks, and basically has proven in a significant number of patients to improve their well-being and decreasing the frequency of vaso-occlusive episodes. Currently, or within the last year, the similar study that brought their approval in the United States was performed in Europe with not really the same response that we found in the study done in the United States. So the company that produced this drug is starting a new study similar to the initial one, but with a larger number of patients and with 2 different drugs of the medication to try to corroborate the results of the first study and see if the use in other countries, not in the United States, can be supported. Lastly, Voxelotor, who is the drug that was also approved in 2019, has a different clinical effect. It was approved under the knowledge that increased hemoglobin levels by at least 1.1 grams per deciliters and reduced hemolysis. And the mechanism of action is that this is an inhibitor of hemoglobin S polymerization, and by decreasing the polymerization, decrease the sickling of the red cell, and thus reverse also the binding of hemoglobin, stabilizing hemoglobin in the oxygenated state. It's important to highlight that Voxelotor was discontinued from the market or voluntary withdrawal just 3 months ago, September of this year, from the manufacturer due to safety concerns that rose during post-marketing trials, especially trials done in Europe and in Africa. But although this was a big backlash for both clinicians, patients, and researchers, we do understand the fact that medications post-marketing we can find more adverse events or other issues that may prevent or break the balance between the benefit and the risk. And this is the situation with one of them. So as you all may know, allogeneic stem cell transplant is a curative intervention for sickle cell disease. Most of this transplant occurs in children that have occurred in children for multiple reasons. It's easier to transplant children from the point of view of having have multiple complications. Although in adults, the main indication is patient having one or multiple end organ damage, such as stroke, recurrent vaso-occlusive episode that impact significantly their well-being and that keep them in the hospital setting for a long time, recurrent acute chest syndrome despite the use of hydroxyurea and other medications, and presence of pulmonary hypertension. This data here, which is a collection of data from multiple studies, basically put together data from almost 3,000 recipients of bone marrow transplant, both HLA, from both HLA and matched donor. And this is data up to 5 years ago. So what we see from that data is that most of the patients achieve a very high overall survival of more than 96%, and in fact in adults was a little bit higher. But that the engraftment or the stability of the engraftment of the transplanted stem cell of bone marrow was higher in children than those in adults, and that the occurrence of graft versus host disease was around 10%, especially the chronic for all the patients, less in a patient with adults. And also there was a significant number of acute graft versus host disease, i.e., graft versus host disease that happened within the first year of the transplant. And this here kind of goes deeper on this data. They're also showing again the different modalities of allogeneic stem cell transplant. In just as a side, there's multiple type of bone marrow transplant. Some of them uses the bone marrow cells, but most recently, most of the bone marrow transplant have been, or the allogeneic stem cell transplant, basically the cells that are transplanted are obtained from peripheral blood from the donor. And the key thing is that most of the transplant are successful if there's a HLA match between the donor and the recipient. And also the preparative regimen used for the transplant is very important. Those that are ablative tend to be a harsh bone marrow transplant, but are used for patients that do not have a full match. And as you see, the possibility or the risk of graft versus host disease is much higher. Right now, when you have a non-ablative, non-myeloablative, or a reduced intensity regimen for transplant, you can see that the incidence of both the acute and the graft versus host disease is less, but the stability of the engraftment tends to also be less. The survival is again around the same, but it's a little bit better if the non-myeloablative or reduced intensity is being used. Then I would like to move now to basically discuss how on a regular basis we treat patients with sickle cell disease with this overall therapy that we have available. Dr. Saraf will address a little bit more gene therapy, since it's considered a transformative therapy, not a curative therapy in sickle cell disease, but it has early results, have been very good. So when I have a patient with sickle cell disease, I basically start with prescribing hydroxyurea. First, because we have the larger or the longest data on efficacy and safety of hydroxyurea. As I mentioned, it started with the multicenter study of hydroxyurea here in pink, and it has really gone we have data now for approximately 25 years. And this data in the first two set of columns basically show that patients with taking hydroxyurea, the annual crisis rate is significantly decreased in relation as compared with placebo. Then the key thing is to try to treat the patient with what we call the MTD, that refers to maximum tolerated dose. So the maximum tolerated dose is that dose that the patient can take without having significant secondary effect. It's interesting, when I was hearing Judy mentioning before, she mentioned that the dose that she thought that she was initially, 1,000 milligrams, was associated with that paralysis, as she called it, and difficulty moving. We tend to start patients at a dose of 15 to 20 milligrams per kilogram, even though studies presented at the American Society of Hematology meeting that just happened last week, or was completed last week, showed that in Africa they were able to start children with an initial dose of 25 milligrams per kilogram on a safety basis. But what we do again in clinical practice is start the patient around at a dose of 15 to 20 milligrams per kilogram. And the key thing is to go up on that dose fast as possible, even to every 2 to 4 weeks, while we evaluate for the adverse events, which are mostly from the laboratory point of view, neutropenia, thrombocytopenia, and reticulopenia. Some other patients, we have to adjust the dose or not able to go higher because of developing GI symptoms such as nausea, abdominal upset. Some patients develop headaches. I don't recall any patient developing the symptoms that Judy mentioned, but again, like in other medication, different symptoms happens in different people, and we have to be very observant of that. Some patients, to tell you the truth, will even notice cosmetical issues such as darkening of the nail beds and thinning of the hair that will be enough for them to decide not to continue with the dose escalation. But again, my message here is that it's important to try to obtain and keep the patient on the maximum tolerated dose. Then the glutamine, again, is the second set of columns that you have in this graph, also show in the phase 3 study that there was a significant decrease on the annual rate of crisis as compared to placebo. Usually, we use L-glutamine either for, in addition to hydroxyurea for those patients that is still either are not able to take a high dose of hydroxyurea or still with hydroxyurea have frequent pain crisis. But overall, the use of L-glutamine is much less than hydroxyurea. Lastly, the sustained study where they evaluated crizanlizumab at a dose of 5 milligrams per kilogram, and as I mentioned before, is given as an IV infusion over an hour every 4 weeks, also showed that there was a decrease on the frequency on the annual crisis rate as compared to placebo. But as you see also, the number of crises that patients had when the multi-center study of hydroxyurea was done versus on the sustained study was much less. And part is because a lot of patients, although not all, that participate in the sustained study for crizanlizumab were already on hydroxyurea. Then what do we do when either the patients still are having significant vaso-occlusive crisis or are having other complications, multi-organ damage that we need to move on? So that's when we think of clinical trials for a significant number of drugs that are currently under development to address different issues with sickle cell disease, such as anemia, vaso-occlusive episode, hypoxia, hemolysis, oxidation, etc. Or we discuss with the patient, and this should be done sooner than early, the availability of allogeneic hematopoietic stem cell transplant. We'll talk next about some of the challenges with this medication, with these interventions and medications, but that's usually the sequencing of treatment that we do. Lastly, gene therapy, as you know, was approved in December 2023, is now being offered or getting ready to be offered in different institutions, and hopefully will also make a difference regarding sickle cell disease. The backdrop or all these interventions is that they provide a lot of challenges, from the access to the drugs, to the utilization of the drug, the social drivers of health, as simple as having transportation to come every 2 weeks or every 4 weeks to have the labs necessary to monitor response to hydroxyurea, to a specific related agent. So this graphic here just highlights some of the challenges that we have when we discuss with the patient any of these interventions, that again are relatively a small number of interventions, especially if you compare with other diseases such as cardiovascular diseases, renal diseases, that we have multiple medications that can address different complications of these diseases. But at the same time, none of them, this drug that I mentioned before, intervention, we haven't been able as a scientist and clinician to optimize because of all these challenges. So I would like to open with the rest of the faculty, Dr. Saraf and Maya Bromberg, to discuss further what are the challenges that they feel that are more relevant regarding treating sickle cell patients at different stages of their life? And now, what are possible solutions?
I mean, this is a loaded question. There's so many different factors. I think a big one is just the general mistrust that is so deeply rooted. I mean, just there's countless instances of medical exploitation and generational trauma, and I understand where it's rooted, and I try to validate and get on my patients' levels when discussing it with them, but it still is very heavy, and it prevents a lot of patients from wanting to use therapies that are very well studied for decades and decades and have such compelling data. I think another one are just the social drivers or the social determinants of health, which really impact every aspect of somebody's life because it's the conditions you're born and grow and live and work, and really those wider set of forces that impact the conditions of our daily life. And when we think about health disparities, if we're just trying to focus on sickle cell, we're going to miss the mark because there's so many other factors that contribute to a person's ability to achieve optimal health. Thinking about the social determinants of health, we know that social and economic factors account for 40% of somebody's health outcomes. So these are things like their income and transportation and all the things that can access somebody's ability to attend clinic visits and start treatment options. So I think the biggest challenge is really the social determinants of health and just really dismantling the structural racism that our country was founded in. I read an article that spoke about structural racism and systemic racism, how it's the invisible evil because it's just so pervasive, but we're kind of used to it and don't really realize it. And we really need to start addressing that. And I think the best way to overcome that is to have a social worker or somebody embedded who is able to do these psychosocial assessments and tries to identify what the barriers are from a patient to making it to clinic, what the barrier is to receive their medications and just receive the standard of care to just give everybody a fair shot to having equitable health.
Yeah, I completely agree with all of those points. I think that understanding, and these are points that were brought up earlier, just understanding how these medications work, explaining the potential side effects, and how you may have some benefits, and then a shared decision could probably help with a lot of these things, such as the fear and the mistrust, any of the bias and assumptions. Another point that I think Maya was discussing was having a great navigator with the chronic disease and with the social and other challenges that our patients have. Having a navigator that helps make sure that the patient has access to the pharmacy, the copay is manageable, or helping with things like the prior authorization, which is something we spend a lot of time in our clinical care working on. And then access to curative therapies. I think that the regimens are slowly improving, but what kind of patient can tolerate myeloablative chemotherapy that Dr. DeCastro had mentioned? What are the risks of things like graft versus host disease, the financial toxicity of gene therapy and the cost right now. So all of those are really important things that we have to consider on a patient-by-patient basis.
It's also the treatments that we have are somewhat missing the mark. We have some hydroxyurea, I'm obsessed with it. Anybody who knows me, I will rave hydroxyurea all day and all night. But we have crizolizumab and Endori, which can help with pain, but it has no impact on your hemoglobin, which can help for our patients with SC and sickle beta thalassemia plus, who, if you speak to the patients, a lot of times they feel like they're almost neglected from clinical trials and therapies, since so many of the therapies are focusing on the anemia and have criteria of hemoglobin between 5.5 and 10.5 and might prevent patients who are interested in participating in clinical trials from actually enrolling and being able to. So I think I'm happy to see that there's been progress, at least from the pharma side, where they are including the community-based organizations and really trying to capture the patient voice. And when we're looking at clinical trial designs, we're starting to see more of the patient-reported outcomes and different measures to address the quality of life metrics, because I think providers oftentimes are very scientific and heavily focused on the objective markers and the effects on hemolysis and hemoglobin, et cetera. But there's so many other factors that are more important to patients, like the fatigue and the functional limitations that sometimes can go unnoticed if we're not intentional.
Yeah, so that's a very important segue to the next question, which is, given that 3 out of 4 medication, or the 3 that are approved, are basically target to vaso-occlusive episode, what are some of the other major unmet needs in sickle cell treatment? What are your thoughts about that?
I think the chronic organ damage is something, if we can have more directed therapy, that would be amazing. I think not everybody can tolerate hydroxyurea, and I think we need to have more disease-modifying drugs that really are addressing that core pathology that's contributing to a lot of the morbidity and mortality associated with this. And it's frustrating because you would think with more and more treatment options in the pipeline, it would make the pricing a little bit more aggressive. And unfortunately, it seems like it's almost driving up the prices. That just making sure, again, that there's access to these treatments. Like, how helpful is it to have a transformative or a curative treatment if we can't even offer it to our patients? Maybe the institution doesn't want to take on such a potential thing that could cause a financial insecurity if they're not reimbursed and things of that nature. But I think the biggest unmet needs is just access to treatments, and then also the individuals who aren't severely anemic, but they're still having the fatigue and having pain and might not benefit from some of the treatments that would otherwise raise their hemoglobin.
Yeah, I agree. I think disease modifiers are definitely needed, and I think all patients should be on disease modifiers. One of the challenges is that the FDA relies solely on vaso-occlusive episodes as an endpoint, and so we're missing a lot of effective therapies that could help protect organ function. I think mental health is also a very important unmet need. Having a chronic disease that causes so much pain and other morbidities really needs mental health integrated in the care. And then one thing that I know there have been efforts to try to treat are things that actually help resolve a vaso-occlusive episode. I think that there are some therapies in the pipeline that will hopefully have some benefit, but right now we rely on IV hydration and pain medications, and maybe sometimes transfusions, but I think that's another unmet need.
Yeah, that's a really good point, because I think it's very exciting because a lot of the treatments in the pipeline are focusing more on chronic maintenance and management of sickle cell, but we are looking at acute management that, well, ideally, if it works, will help reduce the severity and the duration of that pain episode. And like you said, with the mental health, just, I don't know who all is listening to this, but beyond just the physical impact of sickle cell, the psychological impact of sickle cell is so profound. It's arguably worse than the physical impact. And this is because of the judgment and stigmatization from providers, where the majority of patients will avoid seeking medical treatment to avoid the judgment and the mistreatment. And unfortunately, by the time they decide they can't control their pain anymore, they then go to the hospital and are met with resistance by doubting providers. The psychological burden of just not being believed and doubted, and even for the family members, and just feeling like a burden, it cannot be understated. And that mental health support is just, I don't think we can ever have enough support from that end.
Yeah, I completely agree with that. And we could be talking about these unmet needs and how to address them for a long time. Every thought is very welcome, but we wanted to continue with this presentation and welcome back Dr. Santosh Saraf to discuss moving to long-term disease management in sickle cell.
Yeah, thank you. And I do think that it is a really exciting time. I do think that we have better targets, really interesting things in the pipeline. And starting off with gene therapy, this has gotten a lot of buzz in the literature and in the news. And here, instead of relying on other people's stem cells, here it's your own autologous stem cells that are being modified. So they are collected using plerixafor modified ex vivo, and then they are reintroduced back into the patient after chemotherapy. And currently the regimens use busulfan, so it is myeloablative therapy. So that is one caveat to that. But then the modified stem cells are infused back. And two of these agents have had really promising outcomes. One is Exocel and the other is Lovacel. They have different mechanisms of modifying and targets within the stem cell. One is a CRISPR that targets BCL11A, and the other one is a lentivirus that introduces a non-sickling hemoglobin A. They do have this potential cure, although we need long-term follow-up to understand that. And there are also some challenges, cost being one of the major barriers, along with the preparative regimen. But the clinical data and outcomes are very robust and very encouraging. So if you can look at this swimmer's plot, Those blue dots represent vaso-occlusive episodes. And pre the gene therapy, you can see lots of vaso-occlusive episodes, and those really subside post-engraftment. And you can also see that the severe vaso-occlusive episodes requiring hospitalizations are markedly reduced. And this led to Exocell's FDA approval just about a year ago, as well as Lovacell. This also shows really remarkable improvements in the vaso-occlusive episodes. Here you have the severe and mild ones, and you see that they are very much mitigated post-infusion. And so both are currently FDA approved. Their major endpoint is to improve vaso-occlusive episodes, and there's long-term studies looking at other things like quality of life and organ function that we're still awaiting results on. So now, before we move into some of the investigational agents, let me ask the audience a question. Which of these investigational approaches to sickle cell disease treatment do you find the most interesting? All right, great. Well, most are familiar with pyruvate kinase activators or the hemoglobin S oxygen stabilizers. So let's go through some of these newer agents and some of the clinical data. And so this figure highlights some of the different targets that we have to help with sickle cell disease. The first including reactivating fetal hemoglobin, which is similar to what hydroxyurea achieves. So there are two agents, decitabine and pociredir. There's the hemoglobin oxygen stabilizer, the next generation, called osavallator. The pyruvate kinase activators, mitapivat and etavopivat, and then several different downstream targets. So starting off with the hemoglobin F inducers. So somewhere around 6 months of age, our body switches from the gamma globin gene production to the beta globin gene production, so switching from fetal hemoglobin to hemoglobin A. And the beta globin gene is where the sickle mutation is. So if you can revert back to that fetal hemoglobin, that can help mitigate some of the acute and chronic complications of sickle cell disease. And so decitabine tries to play on that genetic and molecular machinery. One of the ways that the gamma globin gene is shut off is by methylation. And so decitabine helps lift that methylation so that the gamma globin can be re-expressed. And so decitabine, when combined with THU, this allows it to be an oral form. It's shown promising results in phase 1 studies where at the therapeutic dose that's now being tested forward, the F cells and the fetal hemoglobin improved. And now this is in a phase 2 study. The other agent that works on these epigenetics is the hemoglobin F inducer pociredir. This also works on gene expression, so it tries to reactivate the gamma globin gene expression. And with incremental doses of the pociredir, you can see that the fetal hemoglobin continues to increase, and you see some remarkable benefits here at the 12 milligram dosage. And so this is also now in a phase 1/2 study. Then there's also the pyruvate kinase activators, and this has received a lot of data recently in publications as well as at the American Society of Hematology. And the mechanism is that it helps improve glucose metabolism by activating pyruvate kinase. And by doing so, it lowers 2,3-DPG. And that allows more oxygen to be bound to the hemoglobin S. That blocks the polymerization. But it also increases generation of ATP. And ATP is really important for membrane health and repair. So this can have kind of a double-sided sword effect in sickle cell disease, where you help reduce hemoglobin S polymerization and you improve red blood cell membrane repair. And so this may help both improve the hemolysis as well as reduce the vaso-occlusive episodes. So here are the two different targets. And the clinical data does tend to support this. So this was the etavopivat phase 1 study where patients were given etavopivat, and you could see that the hemolytic markers showed that the hemoglobin all trend for the most part in a positive direction in those that were on etavopivat, while the reticulocyte count comes down, consistent with improved hemolysis. And also, when patients were on the etavopivat in the open label extension arm, you can see that the longer that they were on treatment, the less vaso-occlusive episodes they had. And so this encouraging data led to the etavopivat phase 2-3 hibiscus trial. This data was presented at the American Society of Hematology just a few weeks ago, where it showed that the rate of vaso-occlusive episodes was reduced by almost a half. When you looked at the per protocol treatment, you could see that the rate was 0.66 in the treatment arm versus 1.77 in the placebo arm. And it also helped push back the time to the first vaso-occlusive episode, almost double that time. Mitapivat is the other pyruvate kinase activator, and very similar efficacy and result data, where you can see with incremental doses, the hemoglobin concentration improved. In a long-term phase 2 study, there was also this consistent and sustained improvement in hemoglobin, while the reticulocyte count, marker of hemolysis, improved in most patients. And again, when you look at the vaso-occlusive episodes, very similar to etavopivat, those patients that were receiving the etavopivat study drug had a reduction in the rate of vaso-occlusive episodes, almost approximately in half. So shifting to downstream targets, and here there's a lot of different targets. So sickle cell disease, we think about just this hemoglobin S mutation leads to sickling, but it leads to this cascade of really maladaptive changes downstream. There are targets that target the von Willebrand factor activation, complement activation, free heme causes a lot of organ injury and complement activation, so hemopexin can help sequester that. Replacement of nitric oxide with arginine, and then other therapies that may have benefit. So a lot of these are being tested in phase 1, 2, and 3 level studies. And this is a table just kind of giving a broad overview of the exciting different agents and the clinical trials that are available on clinicaltrials.gov. So there are things in the pipeline. There are things that help that are being tested to see if they help the hemolytic anemia, reduce vaso-occlusive episodes, and there are some treatments that are being investigated to actually mitigate the actual episode. So we're hoping that we can get some of these that will advance into phase 2, 3, and then hopefully lead to more therapies for our patients. So with that, one final question before we end. How often do you enroll your patients with sickle cell disease into clinical trials for sickle cell disease treatment? The answers include sometimes and some for always. And I think this is a really important point because when we think about patient perspectives, this is a really interesting study, the Global Listen Survey, where over 1,000 people with sickle cell disease from 17 countries were surveyed. And although we kind of think about the prior history of people's exposure and experience with clinical trials, most patients with sickle cell disease were likely or very likely to participate in a clinical trial if offered. So key reasons that were cited included supporting development of new treatments, increasing self-knowledge about sickle cell disease, an opportunity to receive your own data, and the possibility of receiving treatment regularly after the trial. And I think this also kind of highlights that our patients do still feel that there's a great need for therapies. And I think that as providers, we also tend to agree on that. So with that, I'd like to open it back up to the faculty for a discussion. And one of the questions that I'd like to kind of hear feedback on is, when would you recommend clinical trial enrollment for a patient with sickle cell disease?
Well, I think it depends on the institution itself and what you have to offer. So at our institution, we were approached by so many, and we had to be very selective on which ones we enrolled. Otherwise, it's kind of competing studies for the inclusion-exclusion criteria. But when patients meet those inclusion-exclusion criteria, they're not optimized with their current regimen, and they're still having pain, or they're still having frequent VOCs or healthcare utilization, blood transfusions, and we're not able to manage them with the available treatments, especially if it's somebody who is very compliant with regards to making it to their clinic visits and can actually meet the study design and make sure we're not going to get a ton of deviations. But I think it's something that we need to approach all of our patients about, because I think when we're talking about or thinking about health equity, there is just African Americans and Hispanics are consistently underrepresented in clinical trials. And it's important for our patients to understand that we use these results to generalize for a larger scale and why it is important to enroll and participate in clinical trials. And I think providers also need to reflect on their own implicit biases that might impact which patients you approach to participate in clinical trials, when in reality, everyone should have an opportunity if they are deemed to be a good candidate. So I usually will discuss in the clinic visits the things that are going on in the pipeline and any clinical trials that we have and kind of gauge an interest, because I think for the providers in the sickle cell space, we can see a lot of what's going on behind the scenes, but to a lot of patients and caregivers, they feel like it's the same story, nothing's happening, there's no improvement. So I'm more proactive with this dialogues and conversations. So then once we do have different studies available and they are candidates, it's not the first time that they're necessarily hearing about it.
Yes, I would tend to agree with the fact that, even though there's multiple studies open, not all institutions have the availability of do much more of those studies. In fact, in my institution right now, we are having a meeting prioritizing studies based on our researchers' interest in our patient population and the duration of the study, etc. But at the same time, I agree that we should have the knowledge as clinician and as researcher and be able to pass that information to our patients about the availability of this type of studies and be the bridge between the patient and the institution or the group that may be able to enroll this patient in the different studies. For me, this data that Dr. Saraf presented and that I saw at ASH was very eye-opening, although my experience that when we approach patients to do this research, in general, they are very willing to do the research. What happens is that they get sick in the middle or that they have other issues, again, so from simple things like transportations and other things that may prevent them to participate in the study. But usually the first reaction is tell me more and let me see if I can participate. And very often I also see patients that come and say, is there anything in the pipeline? Think of me when you're thinking about A, B, or C study. So the referral base is important. And also, especially there's some of those studies that support some of the patient going to the different centers to get the study done. And there's always also other studies, especially psychosocial study that can be done long distance, that the patient doesn't have to be in person there. So again, my quick answer is sooner than later, and it's a part of knowing about the studies and then having the availability to discuss it with the patient and to refer them to those studies.
And I think also just the patient-provider trust. Like, it's easy for all of us to enroll our patients and to have an interest, but it's because we view our patient-provider relationship as a relationship and a partnership and not a one-sided interaction. And I think it just speaks volumes of why it's so important to nurture these relationships and view it as a partnership as opposed to you being the provider, them being the patients, because I don't think all institutions and all providers will see 56% and more than half wanting to participate in clinical trials. But I agree with everything else you said. Just want to give us some credit.
All right. Well, now I'd like to share SMART goals with our audience. That is what we hope you can integrate into your practice after today's program. Consider factors beyond pain when assessing disease severity. Educate patients on available treatment options to make informed treatment decisions. Select treatments that address underlying disease pathology rather than just symptoms. Identify patients who might be appropriate for clinical trial enrollment. So at this point, we'd like to invite the audience to ask any questions they may have. I think we're a little bit over the time limit, but perhaps we could go through a couple of questions. Okay.
I see some here. In some countries, like most developing ones, where trials may not exist, what would you recommend for sickle cell patients? So I think from the developing countries, I must say I have seen a lot of clinical trials occurring in lower resource areas. My big question is when we're thinking about voxelotor and the emergency withdrawal, some of it was based on data in these other areas, and it kind of makes you question the protection that exists in some of these other countries. But I think where clinical trials might not exist, the recommendation is really to just go based on the guidelines, and if they have SS or sickle beta thalassemia 0, really emphasize how hydroxyurea is important. And a lot of times my conversations aren't about this being a lifelong drug. I explain, like, right now, this is the best treatment that we have. There's a lot in the pipeline. It doesn't mean that this is going to be a forever drug for you, but we want to keep you healthy, keep your organs healthy. And this is the best disease modifier that we have available for that. But it is difficult. And when we're thinking about health equity, the issues that we see in the United States are just tip of the iceberg in other countries where access, let alone diagnosis, is difficult.
I think context is a great point, Maya. And I think that we may have been seeing that with the voxelotor. And so I think that it is important that these trials are conducted in different geographic and environmental settings so that we know what the safety and efficacy are in these different settings. That's a great point.
Yeah, I think in one of the studies, 30% of the individuals identified as white, which initially you might be surprised, but it just shows globally, like, yes, it does primarily affect African ancestry, but at the end of the day, it can affect any race or ethnicity.
I can answer two questions that were asked an hour ago quickly. One is there a recommendation requirement to screen for sickle cell in newborn, especially if there is a family history? So currently, in all the states in the United States, and for the last 20 years, there's the newborn screening program managed by the Department of Health. When a child is born, sickle cell disease is one of, I believe, 7 diseases that they are automatically tested for. And the Department of Health receive the results, and they are the one that then are very proactive in approaching and connecting with the family, and then connecting the family with a pediatrician that is an expert in sickle cell disease. So that's the best way to do that. If there's any question about not having the test done, there's always the possibility of doing a hemoglobin electrophoresis to make the diagnosis. Contrary to United States, only a few countries in Africa have established newborn screening, and there is a group of the American Society of Hematology working on that. And I'm from the Latin American, there's really only 2 countries, Costa Rica and Brazil, that have the newborn screening. So this is something that has to be implemented more in every country. And if there is a question about family possibilities, so definitely I would recommend to do that testing that is relatively a simple test and not too expensive. Regarding the other question, beyond curative therapy, what strategies are there currently to prevent or slow organ damage? I think this is a very important question because as patients with sickle cell decrease age and now survive 50, 60, 70, Judy, 80 years old, we need to make sure that other comorbidities, hypertension, diabetes, etc., are well early identified and managed, because all those two impact negatively the life of a patient with sickle cell disease. The other component that is always very recommended is a good nutrition, overall impact or emphasis in a good nutrition. Contrary to a few years ago, now we see patients that are obese, and that also impact negatively a lot of the complications such as acute vascular necrosis, cardiovascular disease, etc. So a good, well nutrition, good primary care management to identify early possibility of malignancies or other chronic diseases that can impact their sickle cell negatively more is very important.
And I just want to emphasize what you said is just the lifestyle habits, because at the end of the day, there's no amount of medication that's going to outcompete about lifestyle. So we really do need to hone in on your diet and activity, your sleep quality, preventing infection, identifying those triggers, things of that nature, to just help make sure we're addressing all areas that can impact overall health.
Another thing we're seeing recently is tobacco smoking. So, another lifestyle thing that could hopefully be helpful for both the kidney and cardiopulmonary health is avoiding that.
Even vaping, like it's which is better of the two evils, but we're seeing more and more that vaping is almost more accessible. So you might actually be smoking more than what you would with a cigarette, and it's causing that chronic inflammation that it'll be interesting to see what that data shows from that standpoint.
And there's some data, for gene therapy, people that vape may be at higher risk of some of the toxicities from the busulfan. So lots of reasons to avoid those kind of behaviors.
The pulmonary toxicity. Interesting. I didn't know that.
Yeah.
I like this question, and I'll leave it for you, Dr. Saraf and Dr. DeCastro, since I was not in attendance. But at ASH, was there a sense of excitement about the new agents under investigation?
I will say yes. Yes, there was. And this is a good time for sickle cell. Somebody like me that is a senior in this space and that started with, we only have a few federal departments supporting research and all that. And we have now pharmaceutical companies and a lot of investigator initiated. Yes, there is a lot of excitement still happening. And I'm hoping that that continues to be the case.
Yeah, and I think part of it is old drugs done better, hydroxyurea. There was a lot of pharmacokinetics. There was data now that it might help people with the type SC sickle cell disease. And then there was also the updated hibiscus etabopivat study, which is encouraging. So, yeah, I think it was a great meeting and lots of exciting things in the pipeline.
Let's see if we can get the last two questions in 3 minutes. So one of them we can knock off quickly was that, is there any data on end organ damage with some of the investigational therapies? And ultimately, we need more time to really evaluate the impact long-term from an organ damage standpoint. The hope is if you're reducing hemolysis and improving red cell health, in theory, that should protect from end organ damage, but it's just we don't have enough data just yet to with certainty state that.
And there's the SCD carry study that it's the chronic red blood cell exchanges. So people that do have more advanced kidney disease or signs of pulmonary hypertension, that data hopefully we'll see next year. But that's still pending.
And then last question, could the high rates of death due to cardiovascular complications be related to race? There are so many factors. I think from a race standpoint, when we think about all of the different comorbidities that are higher risk for African Americans, a lot of times it's not a genetic component, and it's not due to biology and genetics. It's due to the systemic racism and a lot of the social determinants of health that we had discussed that impact. I don't know if you all had seen, but at one point we had different calculations for GFR, even different for hemoglobin levels that were race stratified, when in reality, like, why was there a difference in the first place? So we've been calling that out. So it could be related to the structural racism that our country was built on, but slowly we are improving it and calling out and having the uncomfortable conversations. But do either of you have any impact? Because obviously there's so much from a sickle cell standpoint that can contribute to just cardiovascular and just the sudden death that we can see among our patients.
Yeah, I think it's a complicated question. I think that race is tied into access to health care, access to preventative treatment, access to healthy foods. I think that blood pressure needs to be really strictly controlled in people with sickle cell disease. So there are other things that might compound the vasculopathy of sickle cell disease. So I think all of those components are really important. I'd like to thank Dr. DeCastro and Ms. Bloomberg for joining me today. Thank you so much for this great program and the discussion and interesting questions. And I also want to thank CME Outfitters for their assistance in developing today's program. Have a great evening.